Good day. Thank you for taking time to join this therapeutics webinar. My name is Stuart Jefferson, Director of International Sales and Marketing, and I'll be hosting today's meeting. On behalf of therapeutics and the international team, I'd like to thank you for taking the time to join this meeting. And before we begin, just a couple of housekeeping items. Can I just ask, if you're not presenting, if you can turn your camera off? And then also, can I just make sure that you ensure that your microphone is also set to mute to ensure best call quality. Thank you. If you do have any questions in today's webinar, then these can be asked through the Q&A button, which you'll find at the bottom of your screen. We will consolidate these throughout the course of the call, and then we will pose these questions to our speakers at the end of the call. On today's webinar, we have the pleasure of welcoming Mr. Gordon Grovac, Spinal Clinical Lead at King's College London Hospital in London, United Kingdom. He'll be presenting on his clinical experience in using iFactor P15 peptide enhanced bone graft when treating metastatic spinal tumour. In addition to Mr. Grovac, we are also joined by our own Dr. Scott Johnson, who is Senior Clinical Director of Clinical Education with Therapeutics, and he will introduce iFactor and the technology of iFactor in the first section before we introduce Mr. Grovac. Thank you for taking the time to meet today. We do realize that there is a pandemic going on, and so your time is greatly appreciated. Without further ado, I'll pass the mic over to Scott. Over to you, please, Scott.
Great, thank you, Stuart, and thanks for everybody to taking the time to attend this meeting with us today. So the first presentation I'm going to give today is in relation to iFactor, a bit of introduction to iFactor, the science, the technology, and also the evidence that supports the use of iFactor. So when we think about bone grafts, we automatically think of iliac crest autograft, which has been the traditional gold standard for many years, but there are now many more alternative bone graft products available, more than 400 available on the market at present, and it's very easy to consider all of these products as being equivalent, but they're certainly not. There are substantial differences between them. The majority of the products on the market at the moment are simple osteoconductive scaffolds, and these products really depend upon their overall chemistry, porosity, and structure to determine how the body interacts with them and how cells actually then start producing bone. iFactor peptide enhanced bone graft is a composite bone graft which combines an osteoconductive scaffold with a bioactive peptide to form a composite bioactive bone graft. What makes iFactor unique is this combination of a bioactive peptide with a calcium phosphate scaffold to form a biomimetic bone graft. What does the I in iFactor mean? Well, the I actually stands for integrin. So we talk about integrin factor. Integrins are key signaling molecules critical to bone formation and homeostasis, and they're very important when we start considering cell interactions with the bone graft and cell-to-cell communications. So P15 represents a small amino acid segment of type 1 collagen. This is the functional domain of type 1 collagen that's responsible for cellular attachment. And this sequence is naturally occurring within type 1 collagen. We simply synthesize the amino acid sequence synthetically and then bind the peptide directly to the surface of a calcium phosphate carrier, effectively making the calcium phosphate scaffold biofunctionalized. So why use a collagen fragment? Well, type 1 collagen is extremely important when we consider cell interactions. Cells bind to collagen and use the connection to understand and interact with the environment around them. So these binding sites are very important. They also enable the cells to move throughout the environment in response to chemical and mechanical stimuli. Movement alone, a binding site along a binding site gradient is called haptotaxis, and this differs from the more random occurrence of chemotaxis, which is what we experience with or associated with BMP2. So type 1 collagen plays a significant role in cellular interactions, and someone has devoted their life's work to mapping these interactions. And this is called the collagen interactome. And you read this like you would a page on a book. So you read from left to right and then from top to bottom, and it encodes all of the known functional domains for cell interactions on the type 1 collagen molecule. One of these key areas is the cell interaction domain, and that's right in the center pretty much of the type 1 collagen molecule. And this is exactly where we find the P15 peptide sequence. So the cell interaction domain is critical for cellular functions, and it's one of the reasons why this sequence has remained unchanged, largely unchanged, over millions of years of evolution. And that really highlights the biological importance of this area in particular on the type 1 collagen molecule. And this is what that interaction domain actually looks like on the collagen molecule. Here we have a number of binding sites that are highlighted in different colors, including P15. So you can really see that there's quite a close association across all these specific binding sites packed into this interaction domain. So one thing you'll notice from this image is that the P15 is actually a little bit tucked out of the way. It's not actually bioavailable, readily bioavailable on the surface. P15 is an area of the type 1 collagen molecule that only becomes bioavailable during remodeling or during injury processes. And this is probably one of the reasons why P15 is so much more potent for cell binding compared to some of the other peptide sequences. It's really seen as an emergency binding site. So in early studies, researchers actually found that P15 was some 4,500 times more potent for cell binding compared to some other RGD peptide sequences. So we obviously harness all of this peptide power within I-Factor. And I-Factor is a unique mechanism of action which is based solely upon the cell's high affinity for these P15 binding sites. So once attached via the surface integrins, the cells receive chemical and mechanical stimuli which initiate the release of growth factors such as cytokines and bone morphogenic proteins, and that subsequently results in activation of the cells. Those signals will also migrate away from the cells and influence other cells in the local area, stimulating those cells to come to the site of injury and also to differentiate down the osteogenic pathway. Most importantly, the release of and the concentration of these growth factors is entirely within normal physiological limits. So we're not talking about million times physiological dose that you would normally expect to find with BMP2. This mechanism of action is actually very well understood and has been subject of numerous publications in the literature highlighting the biological impact of introducing P15 on a scaffold and the subsequent cellular responses. So the unique mechanism of action that I-Factor has differs significantly compared to that with BMP2, which is another bioactive bone graft. Most importantly, the P15 peptide is bound to the surface of the graft, and that ensures the biological activity is concentrated at the surface of the scaffold, and that provides much more predictable activation of cells compared to BMP2, which is obviously available as a small molecule, but that molecule is free to diffuse away from the implantation site. And in fact, the mechanism of action actually relies upon that to entice cells, encourage cells to the area by a process of chemotaxis. So I-Factor is haptotaxis, it's more controlled, it's surface bound. BMP2 relies upon chemotaxis, chemical signals to elicit its biological response. So I-Factor has a mechanism of action which is based upon the cell's high affinity for P15 binding sites, and in cell culture experiments the effect of P15 is clear, with much higher numbers of cells adhering to the surface treated with P15 compared to those surfaces without. In addition to that, P15 has also been shown to positively influence the early cellular development with a rapid development of cytoplasmic extensions and the extensive active actin filament structure as well. And these are important development processes and changes within the cell, which influence early cell-to-cell interactions and also cell migration. So in terms of the cell migration, by providing specific binding sites on the surface of the calcium phosphate scaffold, P15 improves the ability for cells to migrate and populate the surface more rapidly. This is just an illustration of those cells spreading out across a surface that is charged with P15. So also relevant for today's discussion and the presentation by Mr. Grohovac, one of the additional evaluations we've conducted is to evaluate the impact of P15 on osteosarcoma cell lines. So as a component of our IDE PMA application, we included an evaluation of the impact of P15 compared to normal type 1 collagen, which is obviously abundant within the body, within 6 primary cell culture, osteosarcoma cell culture lines. And the output from these studies clearly demonstrate that the effect of P15 is simply no more, does not adversely impact upon the cell populations compared to human type 1 collagen. So there's no adverse impact on these tumor cell lines. Critical question, does all this science really translate into clinical efficacy? Well, iFactor is supported by a wealth of clinical evidence across a number of different application areas, including our pivotal ACDF study through to intra-patient control studies and also experience within orthopedics as well. And I'll just take a little bit more time just to quickly review some of the key highlights from some of these studies. So our main pivotal study was an IDE study conducted in the US and Canada involving 319 patients recruited across 24 clinical sites. It was a one-to-one randomization iFactor against autograft in single level ACDF. Primary outcomes for including efficacy was fusion, NDI, and neurological outcomes. And in terms of safety, we evaluated the number of complications. Evaluations were at 12 months, 24, and then up to 60 months. Some of the longer term outcome measures will be in publication in the coming months. In terms of the shorter term outcomes at 12 months and 24 months, iFactor was shown to be non-inferior to autograft in all of the 4 primary outcome measures, but also part of the study we included a prospectively defined overall success measure. And this overall success measure, for a patient to be considered as having overall success, they must have successfully achieved all of the criteria in each of the 4 primary outcome measures. So it's really your ideal scenario. The patient has successfully achieved fusion, NDI success, neurological success, and not experienced any major complications. And in that regard, in terms of the overall success analysis, iFactor patients did statistically better than those treated with autograft. And that's the first time any study involving a bone graft has been able to demonstrate statistical superiority compared to autograft in overall outcome measures. So anecdotally, what we observed from the x-rays as well within the study was that iFactor also yielded faster fusion compared to autograft. But we also think that speed of fusion is one element here. We also need to consider the quality of the bone formation. The ideal bone graft material should leave nothing behind but healthy bone at the end of that regeneration process. And this is just a high resolution CT sequence from one patient treated with iFactor, single level ACDF. On the left-hand side, you can clearly see the situation immediately post-op. There's a very dense aggregation of iFactor within the cage. And then between post-op and 3 months, you already see that you've achieved a fusion. And then between 3 and 6 months, that bone continues to develop and remodel, tending towards the properties of near normal bone by 6 months. So I-factor not only giving you the quick fusion, but also restoring near normal bone properties. With the other data that we have and study data that we're able to provide in support of I-factor, this was a 110 patient study involving I-factor in ALIF procedures. This was a study in Australia which yielded high fusion rates at 12 months and 24 months. And the outcome of the study, and these are the words of the surgeon, the study demonstrates a high fusion rate and clinical improvement comparable to the published results for ALIF using autograft or BMP, whilst avoiding the complications specific to those materials. So high level of fusion rate without the potential for the risk factors associated with BMP in particular. This is a very interesting study from Belgium involving patients treated with PLIF cages. In this situation, the patients were treated and used as their own control, so it was an intra-patient control. One cage was filled with I-factor and the adjacent cage was filled with autograft. So it was the same patient side-by-side evaluation of fusion. And at 6 months, I-factor cage yielded a much higher fusion rate compared to that of autograft, 97% compared to 59% at 6 months. And that was a statistically relevant difference. And then at 12 months, that statistical difference was maintained. Again, I-factor still very high fusion rate compared to autograft, which is gradually catching up, but still behind at 82%. It's not until 24 months post-op that the autograft group catches up with the I-factor group. So extremely compelling evidence that I-factor is yielding higher fusion rates and a higher capacity to form bone compared to autograft. So the final study here I just want to mention is our latest study, which involves fusion in a very challenging environment. This patient group was treated with non-instrumented posterolateral fusion in elderly patients. The study was conducted in Denmark, and we're just about to publish the long-term clinical outcomes from this study, but short-term at 12 months, I-factor was shown to yield a much higher fusion rate compared to the control arm. So that control arm consisted of allograft mixed with local autograft. This particular study was extremely challenging in terms of bone regeneration, not only because you have the mechanical instability, because you've got a non-instrumented fusion, but also because this is an elderly patient population in which the bone regeneration capacity is impaired. So that's just a very quick snapshot of I-factor, some of the basic science, and also leading into the evidence. All of the preclinical information and data supporting I-factor applies equally to all of our products. So I-factor Putty, FlexFR, and also I-factor Plus Matrix. Not all of these products are may be available in your own territory. However, all of them contain the same P15 peptide technology, which underpins I-factor. Thank you, and I'll be happy to field questions at the end of the meeting.
Thank you very much for that presentation, Scott. We're now going to pass over to Mr. Grovak. So Mr. Grovak, when you're ready, you can share your screen. That'd be great. Thank you.
Okay. Thank you for inviting me. And I would like to go through the clinical experience, my clinical experience using the I-factor peptide in the patients with metastatic spinal disease. But first of all, I want to do the slight overview of the clinical data, which in the patients who have been treated for metastatic spinal cord compression. So what do we actually know about the patients with the cancer? Do they live longer? Well, 5-year survival has significantly improved from the 50s, when it was only 35 patients had a 5-year survival who has been diagnosed with the cancer, which significantly, as you can see, almost doubled in the 2009-2015 time frame. This comes also from the American USA database. It is unclear if the patient's survival has benefited anything from those that patients with metastatic spinal cord disease have benefited anything from increased survival. So it's unknown until recently. So there's emerging evidence that the patients live longer. Since 2005, when the patch will completely redesign our way how we treat the patients with metastatic spinal cord disease, we start doing more undecompressive surgery, which and especially instrumented surgery, which significantly improves survival, ambulation, and the quality of the life of our patients, compared only with radiation alone. Surgery is now well established as a critical component in therapeutic management of the patients, and has been heavily investigated by different authors, which explored post-surgical morbidity and mortality in the patient with spinal metastasis. But the main goal of the surgery is always the palliation. It's never the curative disease. So this, as you can see, this data had come from the USA mortality data, which includes from this all the way from the 70s, early 70s to the more recent date. So what the new evidence is showing, how do the patient with the spinal metastasis live longer? Well, this is a single center evidence, which they have done review of 1,500 patients with mean age of 60 at the time of the surgery, and vast majority are males, with a mean follow-up of almost close to 30 months. As you can see, 70% of the cases that have been counted are from lung, breast, prostate, renal, colon, skin, sarcoma, and thyroid cancer, and the majority of the cases have been localized into the thoracic spine, followed by the lumbar, cervical, and then the sacral levels. Surgical volume has significantly increased in their case series, which they've shown the peak starting from 2013 to 2017, and at that time, the same group published also the NOMS criteria for managing the patient with metastatic spinal cord disease. What they have found out, looking in specific subgroups, such as a renal cell cancer, they found that in 2010, they have noticed statistically significantly improved survival compared with the patients who had the surgery before 2011, with 40%, and decreased risk of the death surgery from 2000, especially from 2010. So as you can see, before 2011, median survival was approximately 9 months, and after surgery, median survival has increased to the 16. It's almost like 60% improvement in survival. This is well described on the Kaplan-Meier survival rate, and also you can see here from the earliest, from almost like 20 years, it's a steady increase with significant speeded up the breakthrough in the 2010, 2011. The reasons for patients with the renal cell cancer are due to early detection, also the smart drugs targeting VEGF pathways, rampicin inhibitors, and immune checkpoint inhibitors. So it's patients with the renal cell cancer in the last, I would say, a decade are living significantly longer. Same, it's happening almost with the patients with the breast cancer. The breakthrough year, it's 2016, 2017, because of the implementation of the different smart drugs in the management of the breast cancer. And the mean survival for entire breast cancer cohort was 16.6 months. Decrease of the hazards has been noted in 2016, as I have previously said, because of the improvement of the chemotherapy and different protocols for breast cancer. Regarding the lung cancer, you can see it's a steady rise in the survival of the patients harboring spinal metastasis since the late 90s till the most recently. The median survival for entire lung cancer cohort was only, unfortunately, 4.6 months. So it's quite low, less than 6 months. And so the long-term results for following out the patients with the metastasis due to the lung cancer will be extremely poor. Improvement has showed survival of the 40%, but when we looked at the length of the survival, it's quite modest. The reason? Improvement in the chemotherapy and different smart inhibitors based on the mutations of the primary cancer, especially in the younger patients. Regarding the colon cancer, we can also see the immediate steady state of increased number of survival through the course of the last 20 years, with median survival of 7 months. Improvement was not so, survival was noted with each year, but there was no specific year it was a breakthrough, and a double-day post-survival in the last 20 years. This has been attributable to different systemic chemotherapy protocols and excision and more aggressive excision of the liver metastasis. Thyroid, prostate, and sarcoma, and the skin cancer in sub-analysis hasn't showed any significant improvement in survival with the spinal metastasis in the last 20 years. But as you can see, the whole cohort is showing an increased, when we look through the whole patients, significant improvement through the whole cohort. Between the patients will survive between 0.6 year to the 0.8 years, so around 10 months. What I want to note you that it's a significant drop down of the survival in the first 2 years, which means that the patients with, and initially the cohort was about 1,500, and then after 2 years, it was only 344. So if we want to conclude any kind of long-term follow-up of the bony fusion in the patients with the spinal metastasis, we need to see if the bone fusion can occur earlier than in the first year or less than 2 years, because the long-term follow-up will be extremely difficult, especially when we reach the level of around 4 years, because at that time we will only have about 10% of the patients for a follow-up. So it will be a huge dropout of the patients because of the increased mortality. Metachronous and synchronous metastatic disease, it makes difference in survival. What was the reason? The spinal metastasis required the surgery at the time of the cancer, and that was a synchronous. In the vast majority of the cases, this is a metastasis of unknown origin. And usually the patient will have a significantly longer median survival compared to the patients who had previous cancer and then they develop the metastasis down the line, because the tumor becomes more aggressive and it resists on the chemo and radiotherapy, and those patients succumb to the much quicker to the primary disease. As you can see, there's a median survival is 11 months for synchronous, and metachronous it's only 7.6 months. So we need to have that in the mind. So patients with spinal metastasis also live longer. This has been shown by this big cohort, even though it's a one center, but 1,500 cases is a quite respectable number, which has been followed up consecutively for the last 20 years. What are the reasons that the patients live longer? Advances in cancer detection, early detection, improvement in systemic therapy, surgery, and radiotherapy. They all bring together, and as we know, new hormone and chemotherapy are delivered almost on a monthly basis and also on the yearly basis all the time. And this is constantly evolving area of the improvement in the chemo and targeted therapy and immunotherapy. And that can sometimes have a breakthrough of increased survival or into all cancer. Radiotherapy has significantly evolved. And when we talk about that, we are meaning about SRS, proton beam therapy, carbon therapy, and now it's going to come a flash proton beam therapy quite soon, which is going to be more available. That allowing the targeted high doses of ablation radiation doses while sparing completely sensitive tissue around, which was not the case with the standard radiotherapy till now. Surgery has also improved, and I may need to say that we have improved significantly in intraoperative visualization, moving the frontiers, what we can operate and how safely we can operate, and also use intraoperative navigation, significantly improving the tumor resection methods. When we talk about historically from Tomita unblock resection, it still remains this in our armamentarium. So we're developing also, especially for primary bone tumors, which we primarily aim to do the functional restoration of the spine and minimally invasive approaches. Treatment for metastatic spinal tumor serves as a palliative function, but we need to have in mind that we need to improve the quality of the life and preserve the quality of the life of the patients with metastasis, improve the neurological function or maintain neurological function and remain the spinal stability. Emerging evidence is coming for improvement survival of the patients with the oligometastatic spinal disease due to significant breakthrough in the radiotherapy such as SRS. But is the bony diffusion necessary in the patient with spinal metastasis? What is the role of the bony diffusion? It's like influencing usually we always have a look, as you can see from the previous lecture, that actually the patients, if you have the better bony diffusion, may respond have a less reoperation rate for degenerative disease and they require less surgical revision rates, especially in the degenerative disease, but in metastasis, this is poorly defined. Why would we like to operate the patients with metastatic spinal tumor disease? Because of the tumor progression. This is extremely rare, but more commonly it will be because of the surgical site infection, because it's more common in the patient with metastasis. Wound dehiscence, quite common in the patients who had previous radiotherapy or immediate radiotherapy in the early stage, and failure of instrumentations because of the non-union or breakage of this metalwork which has been put into the patient. But what will influence the bony healing or the bone quality in the patients with metastasis or with the cancer? It's because every patient we know with the metastasis has a poor host for bony healing. Different cancers have a different physiology. Multiple myeloma has a huge bone turnover, especially when you start treating them with the chemo and radiotherapy. Poor nutrition, malnutrition, different comorbidities. We are treating the patients which are much higher age, that the bone quality and bone turnover and biology is much more impaired. And of course, the tumor burden, because the patient will not live long enough that maybe, and also the tumor will cause increased bone turnover and destruction around that operated site. Commonly used decortication. It's a common technique for exposing healthy bone marrow, but in the metastatic spinal cord disease, it gives an increased risk of seeding adjacent tumor to the adjacent healthy tissue. So radiation, it's another confounding factor, which it's well known from orthopedic surgery that it will cause poor interference in the bone healing, and proton beam therapy together with the radiation, but proton beam therapy specifically associated with decreased bone marrow density, especially bone mineral density on the adjacent levels around radiation site. Significantly, it has been noted in the literature that significantly lower fusion rate can be expected in the patients with spinal cord tumors compared with the degenerative disease or with the fractures. As you can see, 54 VS, almost like in the high 90s. Do the patients with bone fusion live longer? I would say some authors try to answer on that, but because they want to see if the patients, if they had the bone fusion, they would benefit from the bone fusion as well and live longer. And the Kaplan-Meier chart here, you can see that the patients have noticed some trend to living longer, but what are the limitations when we interpret this study? As you can see, the limitation of the study, it's only 85 patients included in this study, so significantly reduce the power in the way when we compare with the group from MSK. And from after 1 year, there were only had 28 patients for survival analysis. 5 of them had a fusion and 23 had no fusion seen on the visible postoperative images. From the 40 patients in non-fusion, the 40%, so it means almost 50% from those 23 underwent revision for different reasons, and 10% from those patients underwent because symptomatic non-union, because fusion group luckily didn't need any kind of revision. And we need to know that the patients with metastasis, primary or oncological disease, are difficult to operate because sometimes the reoperation can cause much more complications in the way of the wound healing, because vast majority of the patients will be radiated, and we will go through the radiation field, and then it can cause lots of complications afterwards. So the conclusion from the paper has been noted that the surgeon should feel confident if that the patient outcomes will not demonstrate that the patient outcomes will not be impeded by the bone fusion, but it didn't, because it didn't show the significant statistical significance. Maybe that's only because they only had 28 patients for analysis after 1 year. It will be interesting to see if the survival will be change or complication or operational rate, how it will change if there's much higher group for follow-up after 1 year. Instrumentation failure, there is always the risk of instrumentation failure, which can lead to reoperation, readmissions, and in severe cases, it can cause neurological deficit or even the death. And we know that the heart failure in patients that require instrumentation in metastatic disease ranges from almost like 2% to the 16% in the literature. So it's a wide range of reoperations, heart failure in metastatic disease. Sometimes it's chemotherapy and radiotherapy may decrease the bone mineral density of the normal bone, especially it can affect the tumor-affected bone undergoes recalcifications, and that has been well known, but it takes several months that this happens. What are the risk factors for heart failure? In the literature, we know that it's myelomatous lesions, so multiple myeloma specifically, ECOG more than 2, radiation therapy, previous chest wall resections, because it will cause also the chest wall will give it the stability of the construct in the thoracic spine, and also the construct levels more than 6 levels, positive sagittal balance, and this has been published in the different literature. When reviewing, everything comes from one depending about detection of like myelomatous lesions will come from one paper, another one will radiation will come from another paper, depending how much patients they have specifically with multiple myeloma in some certain groups. Implant causal failures and basic concepts of the failure of the construct. We know the implant failure is defined as the fracture of the failure or displacement of the metal component, such as screw rods, cages, or disassembly of the fixed construct. Or we have a name of the construct failure, which can be dedicated just to the implant, or mechanical failure of the vertebra, which forms the part of the construct. These are all the 10 most common descriptions of the failure of the construct failure because of like for example, angular deformity, periconstruct failure, and the junctional failure, which I have one case of mine, which is a 78-year-old male who presented with the neck pain and bilateral arm pain and unsteadiness, which he underwent three-level corpectomy with posterior fixation from C3 to T2. And the patient developed cervicothoracic kyphotic deformity due to the collapse of the T1 and T2. So why? And it happened quite quickly, rapidly after 3 months after the radiotherapy. You can see here on the CT that the bone quality in 78-year-old patient is quite poor. You can see it, and in the high thoracic spine, in this case, I haven't used any kind of cement augmentation to give more support and resistance in this kind of case. But I'm following this patient. I just seen recently this patient 2 days down the line. He's doing very well and he's still living. And you need to see those patients in the follow-up, even though with significant cervical kyphotic deformity. He had some kind of difficulties in the swallowing, but he refused to do any kind of revision surgery because of the high risk of failure afterwards because of the poor bone quality. And specifically, if you would look to his skin, you can see significant atrophy of paraspinal muscles. So it will be quite difficult and high risky failure rate with the healing, poor healing, because he had received radiotherapy. This is a case of the screw pull-out failure. As you can see, this is a 60-year-old female with past medical history of the breast cancer. She developed severe back pain 4 months after the surgery because one of the screw was misplaced on the right-hand side, more in the lateral edge, and because of on this side, because it was displaced a little bit more laterally, and it starts loosening and destroying the lateral cortex and rubbing the rib on the side, and for that reason the patient underwent the fusion, the revision of the surgery, which is an extension repositioning of the screw on the index level and also on the bulb. This patient is noted that she had the I factor implanted on the initial surgery, and you will see that there is a bony formation on the in the lateral gutters. And that's the first time when I have started using the I factor. One of the first cases when I saw when doing the revision that actually inside I don't see the scarring tissue filled with the ceramics. I actually have been visualizing seeing the bone. So, but do we need to treat every failure? Of course, every failure depends if the patient is symptomatic or asymptomatic. If the patient is asymptomatic, the failure of the construct, in my opinion, shouldn't be treated. But if the patients are severely symptomatic and the survival is quite long, then I think it will be sensible to have a decent discussion with the patient and also with the treating oncologist for maybe subsequent revision surgery. We will deal with we can also delineate on the early postoperative period time, which is less than 3 months, or a late failure rate after 3 months, as it comes from medical decline. Okay, so regarding the bone graft option MSCC, as we all know, golden standard has been the iliac crest, which has been associated with the donor site morbidity. Local bone graft laminas, facets, vertebral bodies usually are avoided in the patient's spinal metastasis because of the potential microscopic invasion of the tumor cells. If you do the cervical corpectomy, because of the invasion of the metastasis in the side of the vertebral body. The whole vertebral, as you know, the vast majority of the vertebral body has been infiltrated by the tumor cells, and that bone is already quite poor quality. BMP has been shown that especially in the patients with the tumors are generally contraindicated because several studies have suggested an increased incidence of tumors in the patients who receive the BMP or supporting the tumor growth. There is no scientific evidence of use of any kind of ceramics in MSCC or primary bone tumors. But what is actually the evidence? Some authors have tried to delineate if there is any kind of evidence of which type of the bone graft is the best in the treating of the patients with the spinal column tumors. In this case, the authors have reviewed 27 articles with 303 patients, which studies are sampling, which are quite small. If you see that the studies are sampled from 5 to almost like 40 patients, they include a whole mix, a mix of the primary tumors, the papers only focus on MSCC, or the papers that are mixing MSCC and the primary tumors. We need to know that we are treating two different pathologies. One are the primary bone tumors, which are extremely rare, and another one is because the metabolism of the bone turnover is completely different in those kind of groups. Follow-up significantly varies from 120 months, almost 10 years, to only less than 1 year. Most commonly has been used in the primary bone tumors, bone ribs, iliac crest, or vascularized allogenic bone grafts, or bone extenders like DBM. Primary fusion rate, as you can see, between the primary and MSCC, it's significantly different from almost 92% to the 80%. And tumor and the junction locations also had a significantly lower fusion rate compared to the tumors on the non-junction tumors. And also when you will compare the lumbar and the sacral regions, they have a significantly lower fusion rate compared to the regions of the cervical and thoracic spine. They have also looked at the combined anterior and posterior fusion group, resulted in a higher fusion rate than only the patients who underwent only anterior fusion, and it runs almost to the 100% to the 86.4%. So, but none of the specific graft options, when it was run the sub-analysis, didn't demonstrate better or worse fusion outcomes with statistical significance when the different grafts have been used. That may be due to the small sample of the study, and second, and small follow-up studies, and also mixing and matching primary bone tumors and metastasis. Time to fusion they have tried to look to the time to the fusion, which is extremely important in metastatic because we don't have 5 years for the follow-up. And it has been noted that the fusion usually occurs around the 4 months. Significant was longer in the patient harboring metastatic tumors, which is nothing unexpected, and patients who underwent perioperative radiation therapy because of radiotherapy makes significant poor bone healing, especially it has been noted from orthopedics from long bones studies. Patients who receive perioperative chemotherapy significantly had a longer bone healing, also makes sense. Patients who did not undergo preoperative embolization of the tumors had also longer fusion rate, time to fusion compared to the patient who had the preoperative embolization. Vascularized grafts were associated with earlier fusion compared with the other grafts. This is my case of the patient who is a 55-year-old with MSCC of the C5 who underwent cervical corpectomy and subsequent chemoradiotherapy. Cervical cage was at that time filled with a DBM, which was my preferable bone substitute. 8 months after the operation, there was no evidence of bone effusion throughout the cage, and you can see it's almost like looks like a hole. You can see the holes on the other side. So the whole cage, whatever I have put in the cage, is completely disappeared. This was the case of what I have said of the construct failure, which underwent an extension of the construct. And in this case, I want to delineate how much bones formation in the posterolateral edges have been done. And you can actually see that the bone has been forming around much more rapidly around in the posterolateral gutters in the patient who received after the radiotherapy, chemo and radiotherapy afterwards. This was only after 6 months after the surgery. This is one of the cases when the bone fusion prevents you from complete failure and can save the patient from reoperation. This is one of the first cases I have done with the most cage filled with the I factor in the patient who underwent C5 corpectomy because of the metastasis of unknown origin. 6 months after the surgery, he is still doing well with complete fusion throughout the cage. he had cage subsidence into the end plate and also pull out the strength. But the bone formation throughout the cage and around the cage was extremely apparent, and the patient was completely symptom-free with no any kind of other consequences of the hardware loosening. This is a 67-year-old female who had a past medical history of breast cancer, operated by my colleague long time ago, and she went to sublaminar hooks fixation, which was quite stable for many years, but unfortunately she developed a compression fracture or pathological fracture of the C4, 2, 3, 4, sorry, this is a C4 with increased C5 radiculopathy, and she underwent cervical corpectomy plus chemotherapy afterwards. She has been showing that after in the cage quite hyperdensity of the filling, and in my opinion this is a good evidence of the bone reconstruction 10 months after the operation. And for my response, it means that she's becoming more stable and she's doing very well. She's one of those long survivals which has been treated more than 10 years with metastatic breast cancer. So the fusion was quite important. This is a 79-year-old male with metastasis of unknown origin, which caused osteolytic lesion of C5. At the end, we found that it was a large B-cell lymphoma, which he underwent cervical corpectomy and afterwards chemo and radiotherapy with 32 grades in that area. And 5 months after operation, he was showing the bone formation in front and in behind the cage. This is a carbon fiber construct, so it's much easier to follow up the bony formation around the cage and while embedding the bone around the edges of the cage with no failure rate afterwards of the whole construct. Okay, this is one of another cases of 74-year-old male with the past medical history of the prostate who underwent large construct beforehand for treating unstable fracture of thoracic spine, and he developed with the increased pain and pathological fracture in cervical spine and underwent the corpectomy infusion with high density developing of the bone within the same cage, and this is a titanium construct. These are the two different constructs. One is the lady with the breast cancer. One is the patient with the now I cannot recall, but I think it's a prostate cancer where he underwent also 2-level corpectomy, and you can see how dense the bone or the filling is within the construct is occurring, and also around the cage even the titanium 9 months after the surgery you can see increased bone formation, and you can see on the lower end plate even the superior end plate of the lower vertebral body is getting more increased bone density. This is the lady of 6 months after breast cancer resection of two vertebral bodies and reconstruction. You can see a thin layer of the bone formation on the anterior and posterior edges of the cage, and you can see that obviously because of my washing, because I don't like to see the clots in the wound in the neck. Despite this is not recommended to wash the eye factor. I have been washing out those neck wounds because you want to prevent the clot or you want to see beautiful instrumentations. I think the spillage of the content from inside may lead to the prevertebral bony formation. So it's quite metabolically, I think, potent bone substitute. But do we have what recommendations do we have for using of the what to use in the MSCC? So what factors influence choice of whether to use the bone graft? What choice of bone graft is used during the surgery in the metastatic spinal tumors? What is the optimal implant for the use for anterior column support? And what is the optimal overall construct design for reconstruction of metastatic spinal cord tumor disease? So the authors have tried to give the answer in 2016, and they have interviewed 31 clinicians from 50, and from 41 responders, they use the bone graft or bone graft substitute to attempt the general fusion, and 1/3 will use the bone graft almost on every time. Most preferred choice of the bone material was allograft, and more so is local autograft. So to me, this raises suspicions if you're using more so a local autograft, especially from vertebral body you're resecting, that you're actually putting again back inside the bone, which is infiltrated with the bone marrow, and the bone which is infiltrated with the primary tumor. Morcella's iliac crest has been used in the 14%, which also raises high morbidity, especially in the patients with the metastasis. Ceramic has been preferred choice only in the one responder from one surgeon, and also BMP has been used by one surgeon as well, which we know that the BMP2, it's quite potent and can cause even tumor growth. So the 3 top factors have ranked and extremely important, especially in the graft selection, that the patient's is life expectancy, tumor histology, and bone quality. Type of the surgical reconstruction, preferred, it was the way of prosthetic replacement, especially with the cages. Structural allograft has been preferred, I would say 1/5 of the patients, and PMMA bone cement, which is the cheapest and most available, it has been only preferred in the 40% of the responders from the study. Some of the surgeons, and you see this is a small number, only 2, structural iliac crest graft or prefer vascular fibular graft of the rib, which I think it's a significant overkill in the treating the patient with metastatic spinal cord disease. Thank you very much, and I'm more than happy to. I hope I gave you the overview, and I'll be happy to answer to any questions if you have.
Mr. Growak, thank you ever so much. Greatly appreciated. And again, thank you for your time. Means I know you're in between clinics as well. So we really value your time. So just waiting to see if there's any kind of general questions from the group. So far, we haven't had any. I think you've covered an exhaustive kind of setup there, which is fantastic. So any questions from anybody? So just as people may be typing questions, just as a reminder that this recording is available in 24 hours time once we've had a chance to edit it, and that will be made available through your local country representative for I-Factor peptide enhanced bone graft. And subsequently, if there's any kind of questions that come up afterwards, then please submit these through to your distributor, who will then get in touch with one of the international team and hopefully be able to answer your questions. There has been no questions that have come up, Mr. Growak, so I think it's safe to say it's been a very exhaustive overview, which has been fantastic. Again, thank you for your time. And to everybody that's been able to join us today, again, thank you for your time. And we look forward to welcoming you to our next webinar series, which we hope to hold within the next month as well. Thank you very much. Stay safe and enjoy the rest of your week. All the best.
Thank you.